Test 1, 2, veterans affair. Test 1, 2, veterans. You got me. Witness mic veterans. Test 1, 2, 3, 4.
Testing, sound check. Testing, sound check. 1, 2, audio check. I see some jump. Take your time. I'm not going anywhere. Testing, sound check. 1, 2, 1, 2. Testing, 1, 2. No one saw that but us? 1, 2, audio check.
We're fine, we're just going to make our seating chart, I think, and then we're done. Sound check, sound check, 1, 2, 3, 4. Sound check for the court reporter. Mic check, 1, 2, 3, 4. You want me to talk some more? You good? You got it?
Good afternoon. This hearing will come to order. I want to welcome everyone to today's hearing on VA procurement. As a preliminary matter, I would like to ask unanimous consent that Dr. Winstrup, Chairman of the Subcommittee on Economic Opportunity, be permitted to join us today. See no objection. So ordered. Over the years, this subcommittee has discussed countless problems in VA contracts, from unauthorized purchase card commitments and hospital construction overruns in the billions, to university affiliate contracts that take years to award, to televisions purchased for hundreds of thousands of dollars but never used, to a material financial statement weakness. These problems run the gamut. Today we will examine the root causes. GAO has just completed an excellent wide-ranging report recommending changes to organization, policy, and process. VA's procurement and logistics organization is very complex. There is overlap, redundancy, and confusion about who buys what. VA has a headquarters run by Mr. Giddens, with 4 organizations awarding contracts. Most of them have multiple locations around the country. VHA's separate headquarters is the Procurement and Logistics Office, run by Mr. Lemon. Below that are 3 regional offices. 2 of them have centralized contracting offices attached. Below that are 18 network contracting offices. Then there are the logistics and prosthetics organizations with their own component offices. The Choice Act independent assessment found widespread concern among VA employees about the proliferation of contracting organizations and their ability to perform. The procurement rules are just as complex. VA has its own acquisition regulations supplementing the Federal Acquisition Regulation, the FAR. They are badly out of date. GAO actually discovered there were 2 different versions simultaneously in force. Then there are many categories of policy, different at the VA and VHA levels. Some supersede and contradict each other. Canceled policies are still being followed. Apparently, VA does not even have a complete list of them. Companies doing business with VA don't know what the rules are, and even the VA contracting officers get confused. The Commission on Care recommends simplifying all this into one vertically integrated supply chain organization. The independent assessment recommended the same thing last year. VA purports to accept the recommendation, but it rejects the, quote, structural solution, end quote, meaning reorganization. VA says, my VA is already solving these problems. It is not at all clear that that is accurate. Regarding my VA, well, what's in it? Some new analysis, some new analytics tools and internal control improvements. Will they be enough to resolve the financial statement material weakness? We will know in a few months. But the big item in my VA is the new version of the Medical Surgical Prime Vendor Contracts, or MSPV. This is an effort to pare down the number of different medical and surgical items that VHA medical centers use and save money by buying them in bulk. It's a good idea. The concept, called standardization, is not new, but the implementation is not going well. The reduction of items in the MSPV product catalog is huge, down from almost 500,000 items to about 8,000. Decisions about which items make the cut and what doctors are allowed to use affect veterans' health care. VA is badly behind schedule in awarding the supplier contracts for these items. VA has apparently resorted to issuing sole source contracts for thousands of them. This undermines the goal of negotiating the best prices. These are very important contracts. VA estimates altogether they are worth more than $4 billion. I look forward to delving into these issues today. I now yield to Ranking Member Custer for her opening remarks.
Thank you very much, Chairman Kaufman, and I agree with everything you've said. I look forward to hearing from our witnesses, especially Mr. Giddens, with whom I met shortly after you took office as the Principal Executive Director of VA's Office of Acquisition, Logistics, and Construction last year. And in our meeting, you promised that you would develop a plan to reform VA logistics and supply chain management. So I'm very interested in hearing about the plan and the steps that you've already taken to reform the system now that we've received the findings of the recommendations from the Independent Assessment Commission on Care and now this GAO report. It's my understanding that VA agrees with the recommendations made by GAO, but disagrees with some of the recommendations made by the Commission on Care, specifically the recommendation that VHA establish a Chief Supply Chain Officer position to drive VHA supply chain transformation and reorganize all VHA procurement and logistics under this executive. Mr. Giddens, I'm interested to hear why you disagree with the recommendation, considering that the GAO, the Commission on Care, and the independent assessment found that the VA's organizational structure for procurement and supply chain management is so confusing to VA contracting personnel and contains duplicative functions. So I'd be interested, I myself had a hard time following the organizational charts, and I know that vendors have brought that same issue to us. I'm also interested to learn more about VHA's efforts to save taxpayer dollars by transitioning to national contracts for medical supplies under the Medical Surgical Prime Vendor Program. A significant problem with the MSPV is that VA's inability to either determine which supplies should be standardized or incorporate VISN and VAMC administrator and staff feedback for non-standardized supplies within its national purchasing strategy. As the GAO identified, VA's move to next generation MSPV without updating obsolete VA acquisition regulations last updated in 2008 seemingly compounds the problem. Considering these existing pitfalls and inefficiencies, I'm interested to know how you will quickly ensure VA's national purchasing strategy maintains both clinical excellence and compliance with program standards. The Commission on Care indicated that over 95% of all clinical supplies in the VHA are acquired using purchase cards. This process of procurement is inefficient and costly, yet its apparent preference by VA administrators implies severe shortfalls in VA's national purchasing strategy, such as the lack of clinical flexibility and significant delays in acquiring much-needed medical equipment and supplies. And I'm sure my colleagues would all appreciate knowing how the VA intends to resolve this issue, and in particular, the use of old computer software that makes the purchasing of supplies so cumbersome. I know that last year there was talk of a commercial off-the-shelf system being purchased to help VA manage its supply chain, so I want to know if this is still a potential solution to address VA's out-of-date IT systems, and if not, why it is taking so much time for the VA to make a decision on that issue. Finally, I hope to hear from GAO about how the VA can improve its collection and analysis of contracting data to better plan for the future and develop strategies to lower the cost of supplies. I also want to know what the VA is doing to attract and keep top acquisition talent. These two themes of inaccurate data collection and lack of properly trained VA personnel are reoccurring themes for almost every hearing in this subcommittee. So I want to know which plans and recommendations can be put in place today to address these two issues. It's important that the VA establish a medical supply chain that is streamlined and clinically effective. Ultimately, VHA's ability to supply medical supplies and medication to patients affects our veterans' access to high-quality health care, and our veterans deserve timely, world-class care. And with that, Mr. Chairman, I yield back.
Thank you, Ranking Member Custer. I ask that all members waive their opening remarks as per the committee's custom. Hearing no objection, so ordered. With that, I invite the first and only panel to the witness table. On the panel, we have Mr. Greg Giddens, the Principal Executive Director of the Office of Acquisition, Logistics, and Construction. He is accompanied by Mr. Rick Lemon, the Acting VHA Chief Procurement and Logistics Officer. We also have Ms. Michelle Mackin, the Director for Acquisition and Sourcing Management at GAO. I ask the witnesses to please stand and raise your right hand. Do you solemnly swear under penalty of perjury that the testimony you're about to provide is the truth, the whole truth, and nothing but the truth? Very well, please be seated. And let the record reflect that all witnesses have answered in the affirmative. Mr. Giddens, you are now recognized for 5 minutes.
Good afternoon, Chairman Kaufman, Ranking Member Custer, and distinguished members of the subcommittee. I appreciate the opportunity to discuss the progress that the Department of Veterans Affairs has made towards transforming procurement and supply chain operations, leading to improved business outcomes that benefit our nation's veterans. I'm joined today by Mr. Rick Lemon, Acting VHA Chief Procurement and Logistics Officer. Under Secretary McDonald's leadership, VA is transforming the way we do business by embracing a more transparent and collaborative culture where we're putting the needs, expectations, and interests of veterans and their families first. We recognize that persistent challenges exist in delivering business solutions that satisfy veterans' needs while simultaneously complying with the vast body of laws and regulations that govern federal acquisitions. VA is committed to continuous improvement of our procurement practices and procedures, leveraging our buying power to achieve cost avoidances, improving our management information system to support improved decision-making, improving acquisition workforce competencies, and executing our acquisition mission in an integrated manner that establishes clear lines of authority. VA has taken steps to improve our internal acquisition processes to better communicate with employees and provide the support they need to successfully carry out their responsibilities. Last December, I issued 2 VA-wide memos. The first stating my expectations of how we will improve the way we do business by transitioning from a rule-based to procurement-based, principle-based procurements, placing greater emphasis on collaboration and rapid sourcing of greater requirements at affordable prices. The second memo encourages having early and frequent dialogue with our industry partners throughout the acquisition lifecycle. Doing so will improve our ability to articulate our requirements and will result in us receiving better proposals and ultimately in better serving our veterans. The agility of VA's acquisition and supply chain communities to adjust to both regulatory requirements and mission challenges continues to improve. The transformation of VHA's supply chain is one of the MyVA breakthrough initiatives. It's focused on establishing an enterprise-wide medical surgical supply chain that leverages VA's buying power to achieve best possible pricing and system efficiencies resulting in lower operating costs. This initiative is a comprehensive approach consistent with the Commission on Care's intent to improve the effectiveness and efficiency of VHA's supply chain and is already driving much-needed improvements in data visibility and quality, synchronization of technology deployments, standardization, contract compliance, and training. Already in fiscal year 2016, VHA supply chain transformation efforts have yielded in excess of $75 million in cost avoidance. The Department has made steady and significant progress over the past 5 years, but admittedly there is more work to be done, as reflected in the recent GAO report. VA agrees with the conclusions in the report, and we're pleased that in most cases we already have strategies in place that align with GAO's recommendations. For example, the Department's initiative to streamline internal acquisition policy and procedures to clearly delineate what is required by law and statute from what are business process improvements. This deliberate separation of policy from procedure will create a more agile management environment that can respond more quickly to stakeholder and customer needs. The Secretary, senior leaders, managers, and members of the acquisition and supply chain communities across the Department are tackling the many challenges that confront us in a transparent manner as mandated by the tenets of my VA. We made progress, but we still have more work to do. We're committed to being good stewards of taxpayer resources and ensuring veterans and their families receive a seamless, unified veteran experience across the entire organization and the country. Mr. Chairman and members of the committee, this concludes my statement. Thank you for the opportunity to testify before the committee today. We'd be happy to answer your questions.
Thank you, Mr. Giddens. Ms. Mackin, you are now recognized for 5 minutes.
Thank you, Mr. Chairman. Good afternoon, Ranking Member Custer and members of the subcommittee. Thank you for having me here today to discuss VA contracting. This is a very important issue. It's essentially about how the money goes out the door at the department. As the chairman mentioned, we issued a report last week that covered a number of topics, and we made 10 recommendations to VA. Today, I'll hone in on 3 key issues. First, VA's confusing and outdated procurement policy framework. Second, its complex procurement organizational structure. And third, opportunities to save money. You may have seen the graphic in our report of a VA contracting officer walking through a policy forest in a confused manner. The trees represent a number of information letters, acquisition flashes, policy memos, and most troubling, 2 active versions of the department's acquisition regulation, which is the key document contracting officers turn to. One dated from 1997 and the other from 2008. It hadn't been updated in 8 years, and contracting officers were directed to consult each. It's not surprising that we found confusion and problems. After we raised these issues, the department rescinded the 1997 regulation, and it also began to cull through over 170 information letters, many dating from the 1990s, to determine which were still relevant. Without clear, consistent policy and guidance, it makes it harder for contracting officers to do their jobs. Regarding the organizational structure, as we and others have noted, VA is a complex organization, and that applies to its procurement function as well. Customers in medical centers have to navigate a complex web of national, regional, and local contracting organizations to buy what they need. For example, the National Acquisition Center, or NAC, is responsible for pharmaceuticals and high-tech medical equipment. The Strategic Acquisition Center, or SAC, which is in 2 different locations, is responsible for prosthetics and patient mobility supplies and services. Adding to the complexity, contracting responsibility for medical and surgical supplies was recently transferred from the NAC to the SAC. While VA took steps in 2013 to clarify the roles and responsibilities of these organizations, we recommended that the department consider additional guidance, and it agreed to do so. Finally, VA can do more to leverage its substantial buying power. When we looked at medical and surgical supplies, we found that contracting and ordering officers are not making the best use of national contracts that have significant discounts, an average of 30%, according to VA officials. In some cases, this is understandable. The ordering processes are extremely outdated and cumbersome. I'll admit I'm old enough to remember when we first started using computers, and that's what this ordering screen looks like. You have to enter the exact item number for the type of bandage you need, for example. Because these national contracts are set up to get the best prices, it's important that VA make it easy to use them. VA is in the process of developing a new ordering interface. A related issue is that while these national contracts are supposed to be mandatory, VA has acknowledged that many purchases are occurring in the open market where these discounts aren't available. The problem is that no one knows the extent of this or where the problems might be because they have not been tracking actuals. The department's in the process of revamping how it buys medical and surgical supplies, and including awarding new contracts, as was mentioned earlier. And in doing so, it'll be very important that the department make sure the full scope of the items that medical centers need are included on these national contracts. This effort is lagging. VA identified a goal of 8,000 to 10,000 items to put on these contracts, and as of July 2016, only 1,800 were under contract. I'll wrap up by noting that VA's medical centers themselves have opportunities to leverage their buying power at a regional level for items they all buy, like landscaping services, elevator maintenance, and eyeglasses. While we found small pockets of this activity, Local autonomy and a preference for using their own contracts have presented obstacles that are difficult to overcome. Mr. Chairman, Ranking Member Custer, this concludes my prepared remarks. Thank you.
Thank you, Ms. Mackin. The written statements of those who have just provided oral testimony will be entered into the record. We will now proceed with questions. Ms. Mackin, is this just a matter of sorting out what each office is in charge of buying, or is the sheer number of offices with similar responsibilities the problem?
I think that the latter point is something the department needs to take a hard look at. As was noted, our report wasn't the first to point out the complexity of these organizations, but time and again, and we ourselves find in going out to the field, to the people who are actually buying these things, they're confused. And so guidance helps, but I think the department needs to take a look at some streamlining activities and what might make sense there.
Have you seen, Ms. Mackin, that, obviously there was a concern previously in this committee about the use of these credit cards or these purchase cards, where they would do multiple purchases. I can't remember what the ceiling amount, which is not to exceed the ceiling whereby they'd have to go through the normal procurement process. It was a way to evade the procurement contracting process, and they would just, do this enough transactions to do whatever the price was that they were doing, and that it was very problematic. Are you seeing any evidence that this is still occurring?
We heard anecdotally, we didn't quantify the use of that for this report, but the national contracts are there for a reason. If they're not being used, there are other options of using a purchase card or having very small local contracts to buy the needed medical and surgical supplies, again, not getting the discounts.
Well, and I think there were also health safety issues involved. I remember in terms of the procurement of tissue and things like that, by evading the normal procurement process, that they were actually getting some contaminated tissues from that process. Why two active sets of regulations that you mentioned, and why not just consolidate? Why haven't they consolidated into one?
Quite frankly, that was a troubling finding. I've never seen anything like that in my several decades of working at GAO, and I just have to attribute it to the lack of management attention, the lack of people looking out for what contracting officers need to do their job. I will say that when we raised it, the department acted very swiftly to rectify the situation, but not updating your acquisition regulation for 8 years is problematic.
Mr. Giddens, where are we right now with our acquisition regulations?
As Ms. Mackin said, we did rescind the one VA acquisition regulation, and we are underway by December 2017 to have available and ready for public comment the update of the VA acquisition regulation. And as I mentioned, we're separating the process and the procedures that we would use to streamline and make business improvements from those that have a regulatory impact. Those of a regulatory nature need to go through the public comment period. And so that's why this effort to update that will take us as we start that and get everything ready for posting in 2017 and 2018. In the meantime, we've taken steps to provide more clarity. We've established a website where our procurement professionals can go, where the most recent policy guidance is available for them to try to streamline that. We'll also be working to get feedback from contracting officers out in the field so that we can take additional steps while we work to update that VA acquisition reg.
Ms. Mackin, why does the VA simply adopt the FAR, the Federal Acquisitions Regulations? Or, I mean, why have a completely separate set of regulations? Is that necessary?
It's very common.
Okay.
I think almost every federal agency has its own supplement to the FAR, and where
Right.
it can tailor the buying to meet its own needs.
Okay. Thank you. Ranking Member Custer, you're now recognized for 5 minutes.
Thank you, Mr. Chairman. I wanted to ask, and this is either Mr. Giddens or Ms. Mack, and I wanted to focus in the GAO and the Commission on Care and the Independent Assessment all found that VHA's pharmaceutical supply chain performs very well, but the medical surgical supply chain performs poorly in comparison. And my question is, are there any best practices that we can identify in the pharmaceutical supply chain policies and processes that could be applied to the medical surgical supply chain to improve the outcomes, both for cost and efficiency?
Yes, ma'am, and that is a finding with our pharmacy program. And I'll mention a few things that we've done, and Rick may want to add some from VHA in particular, because one of the things that VHA did in the Procurement Logistics Office is look at the pharmacy program and adopt some of the things like the formulary. The pharmacy program has a formulary, and here are the drugs that are approved for use. That's the same approach that they're taking on the MedSurg Prime Vendor. What are the items that are approved for use, that are proven to be clinically safe? They do that by engaging clinicians, just like the pharmacy program did when they established their formulary, and then having a robust mechanism to make sure that we are meeting our needs through that prime vendor program, and that we minimize the activity, whether it's with purchase cards or other, that are done outside the MedSurg prime vendor program. Rick, did you want to?
Yeah, the great thing about the pharmacy prime vendor program is that there's clinical involvement and a formulary is developed, it's well published, and we buy off that contract. That's exactly the approach we're wanting to take with MedSurg prime vendor. Right now, I believe we have 38 integrated product teams that involve clinicians that's going to help us determine the requirements for those products, and then when we go to the negotiations, will help us make those decisions on what will best meet their needs. And so as we develop the formulary and catalog, and I think the chairman mentioned the sole source contracts, that are necessary to get the current contract lifted off the ground. But as we can replace those with these clinically driven source contracts, it'll be very similar to what was done with pharmacy. And I think that'll also produce a great outcome in terms of quality and price.
So, thank you. One of the issues we talked about, and referring to page 35 with the page of, it looks like, is it DOS? Is this the original computer language that you're having to find the actual acquisition number? And I'm trying to put together, then we learned that 95% of the purchases are made outside the system with cards. What is the status, and how do we bring this system up to date so it's searchable and we can have a process that anyone can use anywhere across the country? Because this seems unacceptable.
Well, certainly what you're referring to with those blue screens is the MUMPS-based programming that's part of the VISTA architecture, and certainly the integrated financial system and that we use as part of that to identify the line items. One of the things we recently did is we purchased what's called GUI software, but it will overlay that system until we can replace it, and will provide a very efficient, more like a Windows-based environment for our clinicians and.
Are we on path to replace it, though? I mean, how do you find people in 2016 that even know how to use this?
There's a vendor that produces that software that will overlay our VISTA system and
So
allow us
that
to.
normal people can use the
Yes.
system? All right, and then tell me when this is going to be replaced completely so we don't have to use these patches and overlays?
The near-term solution with the graphical user interface that Rick talked about will be deployed in FY17. So we will have that capability fully operational in 17. The larger issue of the department not having an integrated financial management system is one that we're tackling, that we're moving forward with as part of the Federal Shared Service Program. That's an effort that we've started in 16. We'll be making the selection in 17 and working with the shared service provider and start to pilot that in FY18. But that will be the system In fact, that'll reconcile a lot of the issues that we're currently seeing with our workforce, where our workforce has to do procurement in one system, and then they have to turn to another system and enter that data into another system. Anytime you do manual data entry, we're introducing errors in reconciliation. And what this integrated system will do now will work from end to end. So that system, that information is entered once and used many through the system. It is going to be a very powerful enabler for our workforce.
Well, I think I can speak for my colleagues on both sides of the aisle that we will be anxiously awaiting the report on that being installed. So thank you. I yield back.
Thank you, Ranking Member Custer. Ms. Walorski, you're now recognized for 5 minutes.
Thank you, Mr. Chairman. Mr. Giddens, in the past, VA asked vendors to supply surgical products as needed and bill the VA after the fact. This month, VA started requiring contracts to be issued in advance, but there already seems to be a backlog in the issuance of contracts. Companies have raised strong concerns that they are owed money but don't have a time frame as to when they'll be paid. VA apparently owes these companies millions of dollars. What is VA doing to remedy the situation, and will these be processed and paid prior to the end of this fiscal year?
The effort the VHA started in terms of structuring their process so that we procure an item before we use that was started many months ago, back in late spring, early summer, and they're progressing that implementation. As we do so, we have seen some instances where payments to vendors are starting to lag behind, but I know Rick and his team have been monitoring that and working with vendors, in particular with different VISNs.
And do you have is there some kind of a time frame that you look for this to be completed?
Well, it's not a one event sort of thing, because we're always adding more orders, but, and there's I guess a typical type of lag time between when the order is placed, when the product's provided, and when the vendor is paid. There has been some delays due to the new process. But we're working at it very hard as far as using overtime and shifting resources to address it. We're hoping that within the next 30, 60 days, most of it will be worked down. But the other exciting thing is our office has been working with prosthetics and with the Strategic Acquisition Center at OALC to put together national contracts with these implant vendors. And with those, we're going to add tremendous efficiency where we can have a much more streamlined process and fix this. So we'll have a more permanent fix instead of always trying to muscle through an inefficient process that we have now, but we had to do it for regulatory compliance, to commit the orders in advance of using the products.
Mr. Giddens, I have another question. I also heard concerns that implementation of a mandatory and additive pre-authorization process for medical device implants is overly burdensome. It requires an additional three administrative steps from 3 different stakeholders. Could you explain the justification for these extra steps and what's being done to ensure that veterans receive the proper device in a timely manner?
Well, as Rick said, VHA need to make those processes to be in compliance with regulation. And while they implemented those processes, the end state is the national contracts that we're putting in place so that that process on an individual basis on order can be supported by a national contract.
And then, Mr. Lehman, just quickly, this is just something that's gone on in my district, and so I'm interested. The recently released Commission on Care report took issue with the separation of clinical supplies and prosthetic medical devices that have caused problems in coordinating products needed for procedures. It says that it takes the frontline staff members 1 to 3 months to procure simple items through your contracting and medical staff complain the procurement office is not responsive. I've had surgeries in my district be rescheduled the day of because the medical staff didn't have the devices needed for the procedure. I wish I could say this like never happened, it has, and I wish I could say it happened once, but it hasn't. This has happened and continues to happen in my district where some of these veterans get a call day of. Oh, the device didn't come in, or, you know, something happened on the way. Do you think the inclusion of more frontline medical staff in purchasing would improve this?
Well, I think we have to have process improvement, and that will be driven by the national contracts. Of course, with surgeries, as you know, even in the private sector, a lot of times vendors are called in the day of surgery. Maybe it's expensive items that aren't routinely stocked. And then the surgeon, when they're in the surgery, will decide which particular product would best fit with the anatomy of the patient. So there's some risk of that. But we have to, we're looking at it holistically. We're looking at what products we can potentially bring into inventory, so we're not relying on a vendor delivery. We're also going to implement more streamlined processes with ordering officers. So the idea with prosthetics, as well as other national contracts, we want to get away from transactional contracting at the time of need. We want to have well-leveraged national contracts that can be efficiently executed at the time a clinician or someone needs a product in advance of the need, and then have a delivery that's very timely, and we know they got a quality product at a good price. So the national contracts that Greg's group is working on is going to be just a tremendous help. And then we have to work the processes. And some of the, when you talk about what we're doing now with pre-authorization, you're talking about an order in advance to obligate the funds, so we're compliant with regulation. But then we have to finalize the order once we know what was actually used. And then we have two different systems we're doing that in. With the new processes, a lot of those steps can be cut out. And so that's the solution to not only the problem you mentioned, but also the vendor payment issues. We have to unburden our staff and create a very efficient process to get these products and know we're getting a quality product at the right price.
I appreciate it. Thank you, Mr. Chairman.
Retired Sergeant Major Waltz, you're now recognized for 5 minutes.
Thank you, Chairman, and thank you all for being here. I'm going to build on where Ms. Wolodarski was going from, and I just, last week when the VA Secretary testified over in the Senate, they went down the same line of questioning, and I think the question said only 38% of supply orders were made through standing vendor contracts as opposed to 80 or 90% in the private sector. Went on to talk about how VA does it with pharmaceuticals, and it's kind of the gold standard of how you can get cost savings, efficiencies, and the mail order pharmacy gets very high marks. It's the best. And then they went on to just ask the very simple question, what's preventing VHA from doing these kind of master contracts across the board? And the answer was nothing. I guess the question that's troubling me is, even someone who's not really familiar with this just makes great sense. It's the way things are done. It's kind of best practices. Why is the VA Secretary waiting till 2016 to say this? I'm asking all of you, have efforts been made over the years to do what seems, and I'm not trying to make light of this, procurement is difficult, and I've been on the other end of that where I'm running an armory and procuring, and at times you did want to use that card because I had to go get 3 cost estimates to sharpen the lawnmower blade. By the time I got done with that, it probably would have been simpler, more efficient, and more cost-effective to the taxpayers had I been able to use that. But what's really funny, the standing joke is you cannot use that card. That takes an act of Congress. Little did I know it didn't take an act of Congress. Someone's been using them. So I guess I'm getting at and asking you, why did it take this long when this is pretty much standard practice everywhere else?
So I don't know in years past why we didn't move to this area. We've been working this collectively now for almost a year to make sure we get an understanding of what the requirements are from VHA, driving in clinicians, looking at our spend so we put the right contracts in place, so that we put the right prime vendor vehicle in place. That goes live this December. And that'll be the point where I'm sure we will learn some things as we turn that on, and we won't get everything right, but we'll be in a much better position. And we've already seen that leveraging those national contracts provide delivery as well as provide value. So we're really working through the windshield, driving this hard to implement what is a generally accepted best practice. And
I appreciate that. And I don't want, and I know you coming into the job, I guess maybe then I'll move to the next place is as you're implementing and doing this, and I think Ms. Wolodarski was getting at this point on this. The questions we talked about in our office was, are clinical determinations of the primary care providers being taken into consideration? Meaning, are you seeing patterns using data of things that you know you're going to need because that care has shifted in that direction? Are you using that as part of the decision-making on the master contracts?
Yes, we are, and actually that analytics is what informed the work that we're doing to stand this up in December. We're also then working, and I'll let Rick speak a little more of this, how they're teaming in clinicians to help us understand the way forward. But also there's an element in here that Rick talked about with the graphic user interface that's going to allow us to get rid of the blue screen that Ranking Member Custer showed in the book. That's going to also give us standard data. One of the things that we're suffering from now is, if I may, some medical centers call this a water bottle, and others call it a bottle, water. We don't have a standard nomenclature. And if you don't have that standard nomenclature, it's hard to aggregate your data. Now, there's some fuzzy logic algorithms that can run, and some smart computer folks can try to link those together. But the graphical user interface that we'll be deploying is going to lock those fields down, so we all call it the same item, and it's going to make the data analytics even more powerful than
So that's all trying to move forward, because again, I don't want to oversimplify this, but I do think there's somewhat of an analogy here. I go online to shop for a dehumidifier at Lowe's. They tell me which stores around me have it in and how long it would take to get to the other one, and they know I, the user, can see that. I would think what Ms. Bulorski's talking about is the primary care physician should be able to tell where that prosthetic is, or where that device is, or where that medical equipment's at. Is that an oversimplification, or is that the direction you're going to? That user interface and that simplicity of tracking inventory and procurement is just so simple.
That's absolutely the direction we're going to, and starting with standard data, nomenclature, and inventory systems that link to that, so that the field will use that standard nomenclature, is how we will get there. I would submit we really don't even want that physician worried about what's going to be there. They need to set what their requirement is, and then it show up.
Yeah, true enough.
and
And
so
that
that-
is happening. And when you say going live in December, what percentage of those medical facilities out there are going to be in this consolidated supply chain, and who's able to use it?
I believe we'll be at the 70–80% when we go live in December, and that will be available for VHA to use across their enterprise.
Great. I yield back.
Thank you, Sergeant Major Waltz. Dr. Benishek, you're now recognized for 5 minutes.
Thank you, Mr. Chairman. You know, I was reading some of this stuff here about 475,000 line items of medical surgical supplies being narrowed down to 16,000. Is that quite right there?
Well, no. If you look at maybe every item that's available on a federal supply schedule, I think that's where that number came from. The 16,000 in that range is based on our data analysis, is what we're buying now under the old contract. So no, and in the private sector, what we've heard from some like Extension Health and the Cleveland Clinic, they actually, can get down to even a lower number as they do a better job working with clinicians.
Well, I'll tell you what my concern is, and that is this, and that is I worked at the VA, I'm a surgeon, and all of a sudden there would be a new IV catheter, okay, that nobody liked. People that were putting in the IV catheters didn't like the new IV catheters, but the VA changed their brand of IV catheters that they purchased, and nobody seemed to know that that was going to happen. All right, and I can imagine, I use certain equipment in the operating room, but I'm not familiar with another equipment. Mm-hmm. And there's going to be surgeons all over the country that are trained differently, that have different experience, they use different equipment. So you're going to need to have a lot of different equipment. So to me, I understand, having a reasonable amount of equipment, but without input from the practitioners, that's very difficult to do. And I don't see why, Amazon sells 470,000 items, I'm sure, and they procure it probably more efficiently than you guys do. So why don't we have, more emphasis on the process of procurement rather than narrowing down the items because to me, that's a critical item. I mean, when I find out that I'm going to implant a chemotherapy port, and then all of a sudden they change the type of port because they got a better deal, and they didn't talk to me about it, well, I'm sort of upset because I don't know the details of this port, and I'm going to put it in for the first time on a patient that, I'm unfamiliar. That happens, okay? And I'm sure Dr. Wenstrup might have similar experience. So, this is kind of worrisome to me when I hear that your primary method, or maybe not primary, but a significant part of your way of solving this problem is to cut down on the number of things and not improve the overall efficiency. So I just want to make that comment, and it scares me, okay? So, but what is are you going to fix this two-headquarter thing that Ms. Mackin was talking about? This was I can't remember which one it was. The SAC has two separate. What's that about? I mean, how does that? Why are there two separate locations for the same thing?
That organization has two operating locations. It's not that unusual to have. There's a group that's in Fredericksburg and a group in Frederick. The group in Frederick focuses more on services, and the group in Fredericksburg more on supplies and commodities.
Well, I'm just trying to see that there's a lot of things to me about the procurement process that could be made better rather than simply diminishing the amount of possible supplies. You know what I mean? I understand the formulary of how that works in the pharmacy, but even at the VA, and any hospital that I worked in, frankly, has a formulary, and I wasn't very happy with it sometimes because I wanted to use a drug that wasn't on the formulary. So let me ask you this other question. So now if I'm a surgeon and I want to get a product that's not on your thing, what do I got to do?
Well, it depends on the value of the product. Certainly, there's purchase card holders in logistics if it's under the micro purchase threshold, 3,500. We also have network contracting offices that can do buys larger than that for individual hospitals. But then we're tracking what's being bought on the back end for compliance, just to make sure we're buying the right stuff.
Right.
The idea of having a formulary is not that you purchase every product from every vendor. You have to do some narrowing to get the cost savings and value, but at the same time, it's critical that we have clinical-driven sourcing. The clinicians are involved in making the decisions, and then we use that.
What is the clinical process now?
Clinicians participate in the individual teams that determine what the requirements are.
Which clinicians are those? Now, if I go back to the VA and start working again, am I going to have an opportunity to provide input? Or is it somebody at some university somewhere? I mean, is it a limited number of clinicians? Does everybody who does that, use that device, get a chance to provide input?
Certainly, we don't have every clinician in the VA that would use a particular item participating in the team, but they do have clinical representatives that.
That's the part I don't like, okay, because why shouldn't every clinician have an input? I mean, they're the ones actually doing the damn procedure.
They do in a way. We do have clinical product review committees in hospitals.
Okay.
And they forward up the items they want us to look at.
All right, I'm out of time.
Thank you, Dr. Benishek. Mr. O'Rourke, you're now recognized for 5 minutes.
Thank you, Mr. Chairman. Ms. Mackin, wanted to, others have given examples, but wanted to hear from you. Who does this right? Who's the model? Who should we be emulating?
That's hard to answer. I think every government agency has its own set of issues. What strikes us about VA is how decentralized it is. And I think there are some duplicative functions that the department might want to take a look at. As we've noted, as the Commission on Care noted, as the independent assessment noted, this isn't new. I'm not saying it's easy, but I think over time it has become a little too convoluted. And I say that because, again, the contracting officers and the ordering officials at the medical centers are confused.
And something you said struck home with me, which is that this is not the first time that these challenges and shortcomings have been brought to the attention of Congress. And I recognize that Mr. Giddens is new relatively in this position, but it is a familiar theme before this committee, at least in the 4 years I've been here, is, look, the VA's royally screwed this thing up for a long time, but the people who were responsible for screwing it up are gone. We've got new people in place, and we've got these transformational plans that are going to completely, bring the VA into line. You guys got nothing to worry about. So what's cause for optimism do you have, Ms. Mackin, when you look at what the VA is doing right now in response either to your findings or to previous findings, and what causes for concern do you have, and what's your advice to me in my oversight function? What should I be looking at in the years ahead so that we don't find you or your successor here 5 years saying, look, the VA's now got a graphical user interface, but essentially it's the same screwed up system and it's still not working. If you could answer those three questions in the 3 minutes that we have remaining, that would be helpful to me.
I mean, it's a multi-layered issue. You have the procurement policy framework, which I think should be pretty easy to streamline. You want one updated acquisition regulation. You want to get rid of these 170 information letters so people know what they're supposed to be doing. The organizational issues we point out will probably be more difficult to deal with, but focusing in on the medical surgical supply program, I think VA is on the right track. They have national contracts. That's a good practice. You want to get the best prices you can while having all the items, as I mentioned, that the clinical staff need. What was troubling to us there, though, is are they being used? Not as much as VA would hope. How much are they not being used? Nobody knows. They have not been tracking the actuals, and you're not going to get these strategic savings unless you know who's using the national contracts, and just as importantly, who's not using them and why. Is it the ordering interface? Is it the items aren't available? You have to kind of dig down and understand why they're not being used to get the best value.
And to the first question, I mean, any cause for optimism? Is there anything that you're seeing in the VA's response, say over the last year, to these problems before this report was published, and then the VA's response to this report specifically that give you cause for hope or show you that the VA is essentially on the right track?
I mean, during our...
Or not, let me know.
During our audit, when we raised the procurement policy framework, that you have two versions of your acquisition regulation, they took immediate action. I don't know why it took us to point that out. I mean, that's still a concern. But, once we raised the concerns, they did start taking action. And so I think that's a good thing. I think in terms of oversight, are they using these national contracts? Are they getting the best value for the taxpayer? They have a lot in the works. My VA, this initiative is huge and broad, and there's a lot of we will do this and we will do that statements. Right. I think for GAO and perhaps Congress, you want to see the documentation and the evidence that the outcomes are happening.
And Mr. Giddens, just, you don't have to answer this if you don't want to, but my constructive criticism would be that, and it's something that I see a lot of folks from the VA do when they testify before us, they use very aspirational language. We're pursuing supply chain transformation efforts. We're responding to stakeholders and customer needs. What would be very helpful to me is just the numbers. What have you done? What have you not done? When will you do the things that you aspire to do? How can we best hold you to account? The aspirational, we will be the best, we'll deliver for veterans. We all know that. But we know you're in this for the right reason, that you're going to try your hardest. But it's very helpful to me if you could have a concise, by-the-numbers response to, perhaps the questions that were raised today, and perhaps in future testimony. Look, here's where we are. That is very helpful, because I get that from GAO, for which I'm very grateful, and I don't always get that from the VA. And again, you're not unique in that, and I appreciate the aspirations that you set out to achieve. It's just that the numbers are going to be very helpful, especially in an O&I setting.
Sir, I'd welcome the opportunity to do that, to show the plans and the milestones that we have that support those aspirations.
Thank you.
It's going to happen.
Thank you, Mr. O'Rourke. Dr. Winstrup, you're now recognized for 5 minutes.
Thank you, Mr. Chairman. I appreciate the attempt to bring some order to this process. And, Mr. Walls brought up the example of Lowe's. They've got to do these types of things because customer service is of utmost importance. And maybe that's something that's missing from time to time in your situation. But you have tremendous buying power. I mean, what hospital system would not love to have the buying power of the VA healthcare system and use it to their advantage? It seems to me you're holding a lot of cards. And so that goes to withholding all those cards. Sole source type of purchasing doesn't even make sense. Now, you may have something like, hey, a suture removal kit. Yeah, anybody can use the same one. That kind of thing is fine. But it seems to me what we're doing right now is very much related to cost concerns. Now, and doctors get that. We've had to deal with that. And when it comes to medical and surgical tools, though, when you're operating on somebody, it's what's best for the patient. and that patient care comes first and foremost over anything else. And so it seems like we're kind of more contract-driven right now, and the bean counters are making the decisions of what we have and don't have. And, what happens when doctors don't have a legitimate choice, they leave. This happened in our group. One of the hospital systems we were heavily entrenched with said, this is the only knee implant you can use. Well, guess what? It's not the right one for every patient. We left that system. Later, they had to come around. They found a way to make it work. And so, you talk about physician recruitment for the VA, you don't want to tie people's hands when you're trying to get the best in place. And you talked about the vendors delivering that day. Sometimes I'd have two opposing vendors and say, you know what, once I get in there, I'm going to decide which one is going to be best for this patient. That's not a bad thing. That's a good thing. So the question comes in is who's always making these calls for the items that are put in the catalog? Maybe something's in the catalog that you got to say request early, something like that, but don't make it obsolete and in no way available. And I believe what you were looking for is the integrated procurement team that includes physicians. Well, I hope it includes the right physicians, because a lot of times, since I've been dealing with healthcare and the government, they'll have physicians, but not physicians that are familiar with the things they're making decisions on. So we got to be careful on that. So the question does come in: what happens when a doc says, "I need this"? And Mr. Giddens, in August, I think you were on the radio and you were talking about ordering officers that they don't have to decide which is the right kind of bandage. Well, I don't consider that a positive, because there's a difference between Cling and Kerlix and Webril and different bandages, and they're used for different things. So one size doesn't fit all. So sometimes you do have to make a decision on what type of bandage and not just say, well, this is easy, this is the only one you got. And so the questions come in is, what happens when a doc says, I need this? And is it a fact right now that the VA is selecting one company to supply each type of product? Because that, I think, is dangerous. The other question I have is, when do we get to see the catalog and take a look at it for ourselves, if you would, Mr. Giddens?
So first, to make sure that, to clarify one of the earlier points, this is not bean counting first. We're putting veterans first. We think as we do that, we will be able to realize savings. And talking with healthcare organizations across the country, that's what they've told us too, that they could serve their patients and at the same time be more cost effective. They also told us this is not an overnight journey. Some of them said it took them 5, 7, 8 years. So we don't want to rush to this in any way that puts our patient and healthcare delivery at risk. So we intend to be deliberate, methodical, and to make best speed. You mentioned the radio show. The point I was trying to make on that is right now, if you're that ordering officer out in the field and you do a search, you may get 5, 7, 10 pages of different kind of bandages. We want to, based on clinically driven sourcing and getting the right input from the healthcare community, if you're looking for a bandage that has bacterial properties of this and an absorption rate of this, we don't want you to have to look through 5 different pages. We want to provide you the ones for what you need that have already been approved for use in the VA and that we know gives good clinical outcomes.
I appreciate that clarity.
And if we can leverage that and now buy at the market instead of buying at the eaches, we think we can also have some cost avoidance.
And the catalog, when do you anticipate that might be available? Or tentative catalog?
In December. We'll be happy to, as we start to go live, to share that with you.
Okay.
And it will be, as Rick said, it will be evolving. That catalog in December, as we continue to get feedback, as clinicians continue to work on the integrated product teams and procurement teams, that will be adjusted, and we'll look at our spend and our analytics, and so it will be an evolving catalog. It is not going to be static. It will be dynamic.
And again, I know you've heard it already, but the provider input to what they need is best for their patient has got to be a big component of this. And I understand the need for cost savings as well. I yield back. Thank you.
Yes, sir.
Thank you, Dr. Winstrup. Dr. Rowe, you're now recognized for 5 minutes.
Thank you, Mr. Chairman. Rush in the VA is an oxymoron, Mr. Giddens. Since I've been here, I haven't seen them getting a rush for anything. Ms. Mackin, you mentioned confusing, complex, but opportunities. And I hope that we're going to take advantage of some opportunities. And I know that this is a huge system. I understand that. and there have to be, when we've seen abuses of the system, and I know you have to have rigid ways to do it, and I know, Dr. Winstrup, we all like our toys when we go to the operating room, we like what we do, but obviously there needs to be some way that you don't have every gadget in the world on there. We understand that. Dr. Cosgrove mentioned last week when he was here, sitting right where you are, about how a different EHR system would benefit the VA instead of having to lay something over. Ms. Custer mentioned a minute ago about that, it would work for an EHR healthcare system, a supply chain, billing, all the things the VA is struggling with this legacy system. Would that be something that would help, where you have an off-the-shelf system? That's number one. And Ms. Mackin, I guess I've got a question for you. Why did it take an OIG audit to make the changes? Why didn't the VA make those changes before you had to audit the system and point these things out?
If you're referring to the actions that they took during our audit,
yes.
I mean, I have to just think it wasn't on anybody's radar screen enough to start moving. They realized that they had 2 acquisition regulations out there. It just was a very slow-moving process, and then when we raised it, they pretty quickly rescinded the old one, so that was good. But, you know, they're still looking at a couple years before they've updated the 2008 version. They did agree with all 10 of our recommendations. We didn't get the letter in time to publish in our report, but we heard from Mr. Giddens. So we'll be following up on those individual recommendations as well.
Well, it's the, in our Veterans Choice Act, when the Committee on Care came, the VA seems to always agree, but it's the implementation of it that seems to be held up. And what Mr. Waltz was saying a minute ago, you know, I can go to, if I want a product in the world now with the technology we have, I can literally go on Amazon and find 6, 7 different versions of what I want at different price points. I can do that with airline tickets. I can do that with insurance policies. I can do that, and I believe there are health systems that do exactly the same thing, to find the best price for a product in a competitive system. And I don't know whether the VA's system of looking at it won't allow them to do it. I don't know whether that's the case or whatever, but and right now with the technology that's out there, you can find the best price for almost anything now. I don't care if it's a pulse oximeter, a blood pressure cuff, stethoscope, whatever you're looking at. Is that the system, Mr. Giddens, that's going to be in place?
Yes, sir, that's the system that we'll begin using this December, where we have looked and put those contracts in place that supports that, so that when somebody is looking to order, it'll start pushing that with the graphical user interface so that they see the right item and how to order.
It will search out the lowest price for the same product. Is that what you're saying?
We'll have actually already done the analytics, and I can let Rick talk a little about the analytics. We'll have already done the analytics and put the right contracts in place so they are getting that best price, but we'll continue to monitor the market. We may have a contract in place that in 9 months the market has shifted and now that price is not as good. So we want to be looking at what the market prices are on an ongoing basis and understand maybe our contract price is still good or maybe not, and then we'll start making shifts.
Well, that segues into the next question I have, which is in strategic buying contracts, the VA concentrates its business with a few big companies. Small orthopedic implant startup submitted a statement for the record. They say the VA is paying 68% too much with the big manufacturers. The VA seems to shut these small companies out because it's more convenient to get the whole product line from one company. That puts the convenience over competition and savings. How would you respond to that?
I don't know any of the details on that particular procurement. It's probably in VHA.
We can get that for you for the rest. You don't have to answer it now. We can get that for you. I notice my time's about out. I yield back.
Thank you, Dr. Rowe. We'll do a second round for anybody that has additional questions. I have 3 additional questions. Ms. Mackin, GAO's report says VA is working on an updated version of its acquisition regulations, but it won't be finished until 2019. Is this reasonable?
It's a slow process. I will say that they began working on it in 2011. I think Mr. Giddens just said they expect to be complete in December of 2018. That is a long time. I know there's public rulemaking, that's part of it, but it seems like a long time.
Mr. Giddens, Congress has given VA numerous special procurement authorities over the years, none of which seem to make the situation any better. Why isn't maintaining these regulations more of a priority?
Sir, I think as we've looked at that, it is a priority, as we've indicated in working with GAO. We're going to look to accelerate that, but there is a large part of rulemaking and public comment that we must go through as we update the VAR. That's why we want to separate out and only update in the VAR what is required for rulemaking and take the rest and put in a manual that we can more update as business processes are improved.
Mr. Giddens, how can you demand businesses, a lot of them are being small businesses, live under these regulations if VA can't even maintain them?
Well, the regulations that govern us in the FAR don't govern those businesses, large or small. They govern the interfaces that we have with them, but those interfaces are largely defined by the solicitation and the proposal process, which are clearly articulated.
Ms. Mackin, summing this all up, what is MyVA, the program MyVA demonstrably accomplished in the supply chain realm?
I think the goals of MyVA are all good, but as noted, they're very broad and we will kind of statements. I've seen some numbers about cost savings. I haven't seen any backup for those numbers, so that's something I'd be interested in taking a look at. And I'll just say an organization can't manage what it doesn't measure. And if VA can't get a good understanding of, even after these national contracts are up and running, who's not using them and why, they're not going to get where they want to get with the cost savings.
Let me just say, I think Mr. O'Rourke well articulated the need to have metrics. That instead of these aspirational goals, you know, what we want are a plan with specific metrics that we can measure and that you can measure, Mr. Giddens, to say where you are in terms of improving this process. Can you comment on that?
As indicated before, we'd welcome the opportunity to share those plans.
When do you think you can share those with this subcommittee?
We can, next week.
Okay. And I'd like Mr. O'Rourke to take a look at those and see if they meet your objectives. I think they were very well expressed. Any other questions, Mr. O'Rourke, Mr. Waltz? Let's see. Let's see where we at here. Whoops. Where are we at? Oh, first. Okay. Okay. It's right here, right? Our thanks to the witnesses. The witnesses are excused. Today we have had a chance to examine the underlying challenges in VA procurement. I hope VA will consider streamlining these organizations and cleaning up the rules. One final note, VA urges us to pass provider agreement legislation in every single letter we get from the department. Chairman Miller originally attempted to bring it to the floor in May, and it was derailed by last-minute objections to the cost offset proposed by the President that this committee, under both parties, has used for years. Chairman Miller again tried to bring it to the floor just last week. The bill had to be pulled over new objections brought at the last minute by the Secretary of Labor that even VA was not aware of. I reject any implication that the committee has not been working diligently on this legislation. I would ask VA to be vocal in its support when it really counts, not just privately. I ask unanimous consent that all members have 5 legislative days to revise and extend their remarks and include extraneous materials. Without objection, so ordered. I would like to once again thank all of our witnesses and audience members for joining in today's conversation. With that, this hearing is adjourned.
Done. Thank you very much.
Thank you.